Hello everyone, how are you all? So thank you so much for joining today's session for our August sample question discussion class today. So we'll try to do some question solvation tonight, and always remember that these are the questions which will help you to understand like how you should solve questions for your exam and how to find out what are the clues from those questions and what could be the traps in that particular question. When you will be able to find out the clues and the traps from a particular question, at that time you will understand that now you are well prepared for the exam. Always remember that exam questions in AMC will be much more comprehensive, and they usually will not make you confused without giving you any clues. So they will obviously give you enough clues and enough information to make sure that you know what's the case is. So it's very unlikely that they will just give you a one line question and then they will ask you a management or ask you the diagnosis. Most of the time, the questions are pretty good and questions are comprehensive rather than just a little amount of information. All right. So that's a good thing in the exam. Now we are going to start our session now. Just give me 1 minute to start. Okay. So the first question is which one of the following carries highest risk for colon cancer? So for colon cancer, which one of the following carries the highest risk? One, your Push-Jeher syndrome, B, Gardner syndrome, C, familial adenomatous polyposis, D, Lynch syndrome, and E, colonic polyp. What do you think that carries the highest risk of colon cancer? Now, each of these condition has a risk of colon cancer. All these options, more or less, all of them can increase the chance of your colon cancer. But which one is the most one? If you look at this chart from your JM, you will find it out pretty well. So if you look at this one, that hereditary non-polyposis colon cancer, which is your HNPCC, or the another name of HNPCC is your Lynch syndrome. The Lynch syndrome, you have 1:2 lifetime risk, whereas if you have familial adenomatous polyposis, 1:1, that means 100% increased risk of having a colon cancer. So if you have a family history of familial adenomatous polyposis, there is a very, very high risk of getting a colon cancer. That's why we do screening for this population at a very early age. Always remember, for your exam, colon cancer screening is very important. So always make sure that from the ISCGP Red Book, go through the colon cancer screening. Okay. Now, about the other option, the Push-Jeher syndrome, it's an autosomal condition which is characterized by development of some hematomatous polyp in your GIT. And on the top of that, also patient will have hyperpigmented lesion on the mucous membrane like lips or any mucosa in your body. Now in here you can see this is the melanosis or melanin pigmentation on the lips. If any patient having this sort of pigmentation on the mucosa, with that patient also complaining of abdominal pain, or in the colonoscopy you have found out some polyp, always think about Push-Jeher syndrome. That's one of the important question for your exam also. Sometimes they can give you this picture and they can ask you the diagnosis. Another important question related to Push-Jeher syndrome is that if a patient with Push-Jeher syndrome comes to you with sudden onset of acute severe abdominal pain, what is the most likely cause of that condition? So the main thing is that What's the main complication or what's the main abdominal complication of this Push-Jahr syndrome? What do you think? Good, Dr. Ridhima. So, yep, so intersusception is one of the most important complication. 50% patient with Push-Jahr syndrome can have intersusception in their lifetime. The next question that I can ask you that these patients Push-Jahr syndrome, because they develop a lot of hematomatous polyp in the GI tract, they can develop obstruction in their gut. Now, which obstruction is more common, small bowel obstruction or large bowel obstruction? So if you go to the Medscape, so go to the Medscape, then you will find out your answer. So 42.8% patient can have obstruction. Okay. And if you look at here, that small intestine polyps are more common rather than large intestinal polyp. And if you come here, intestinal obstruction can occur in about 50% patients, and it is usually localized in the small bowel. So small bowel obstruction is more common in case of Push-Jahr syndrome patient. Clear? So this was mainly I wanted to discuss with you. The other one called Gardner syndrome, which is also in your option. Now, why I am showing it to you is that when you read a particular question, always try to read the other options also, so that if anything comes up in the exam, you know about this thing and you can easily exclude those things. So always have an idea about all the options. The Gardner syndrome, it's a kind of or it's a subtype of your familial adenomatous polyposis, which is an autosomal dominant form. It also characterized by the presence of multiple polyp in the colon, but with multiple polyp in the colon, they have cancer in outside of the colon also. What are the most important cancers related to Gardner syndrome? Mainly osteoma of the skull, thyroid cancer, epidermoid cyst, fibroma, and also desmoid tumor. That's why there was a question. So if a patient who like pre-pubertal patient, okay, like a like young adult patient having a history of epidermoid cyst or recurrent epidermoid cyst, you should always think about Gardner syndrome, because it could be like patient presenting to you with epidermoid cyst, maybe there is underlying colonic polyp. Okay, so always think about those sort of things. So Gardner syndrome is the autosomal dominant type of polyposis in which there will be colonic polyps. With that, there will be some extra colonic tumor, mainly epidermoid cyst, fibroma, osteoma, thyroid cancer. That's your Gardner syndrome. Lynch syndrome, we already discussed, is also an autosomal dominant. In here, you will there is a high risk of developing early onset colorectal cancer, especially in the proximal colon. But with this colorectal cancer, reproductive area cancer is more common, like endometrial cancer, ovarian cancer. Then also there is a chance of GIT cancer, like gastric or small intestinal cancer. But very commonly associated is endometrial and ovarian cancer with Lynch syndrome. These are very commonly asked question in your exam, like they can easily ask you that a patient having a family history of early onset colon cancer diagnosed to be a case of Lynch syndrome, which is the most commonly associated cancer with this particular condition. So you should know that it's the endometrial cancer which is the more associated with it. So these were our main options. From all these options, remember, familial adenomatous polyposis has the highest risk of developing colon cancer. Okay. Now, sometimes they can give you an option of ulcerative colitis or inflammatory bowel disease. Even if ulcerative colitis is in the option, familial adenomatous polyposis has the highest risk. Okay. Because it's a 1:1 risk of developing colon cancer. Cool. Now, the next question. Patient developed rash after 24 hours of antibiotic. What is the cause? So after 24 hours of giving antibiotic, patient coming to you with rash. First of all, rule out unlikely causes like anaphylaxis. Anaphylaxis should never ever come after 24 hours. Anaphylaxis is always immediate onset reaction to any drugs. And now with rash, anaphylaxis should have tongue swelling, lip swelling, having laryngeal edema causing shortness of breath or hoarseness of voice. Also, sometimes GIT problem can happen like nausea, vomiting, abdominal pain, neurological problem like getting confused, having seizure or getting into coma or having profound hypotension. These are all anaphylaxis feature. So it's very unlikely to get an anaphylaxis after 24 hours. So it's unlikely. Viral rash, again, it's a very vague option here because we don't know if this patient having any viral RTI or not. So it's unlikely. Now, so what is serum sickness? Serum sickness, there are two types of serum sickness. One that sometimes if you give some like mainly this anti-thymocyte globulin, some of the immunoglobulin which is produced from horse serum, if you give it to this to the patient, sometimes antibody can develop to the foreign proteins that you are giving, and that antibody can combine with the foreign protein and it can produce a antigen antibody complex, or it's called an immune mediated complex. That immune mediated complex can bind to your kidney and can cause a lot of trouble. That's mainly serum sickness. Serum sickness usually occurs after 5 days of giving this sort of transfused serum, or even if some of the medication can give you the similar kind of serum sickness feature. Most of them usually develop fever, rash or urticaria, arthralgia, proteinuria. These features are common. Now, the most important thing is they usually comes 5 to 10 days after the exposure and usually resolves if you stop the medication. Now, beta-lactam like penicillin, cephalosporin are commonly, they can cause serum sickness, but this timing is important. Okay. Now, what left now? Delayed hypersensitivity reaction. Now, delayed hypersensitivity reaction can happen to any medication. Usually, if it is a delayed hypersensitivity reaction, which is your type 4 hypersensitivity reaction, it can usually happens after 24 hours or 48 hours. And usually they will only present to you with urticaria or rash. Okay, clear? Any question about this? Now, yeah, so who asked this question? Joshna. Antithymocytes globulin usually given to people with who has this like kidney transplant rejection, aplastic anemia. For those patients, we can give this sort of drugs. Not very common. Next question, 32 weeks pregnant with history of headache and vomiting for 8 hours. Now settled, what do you want to do? So 32 weeks pregnant patient had with a history of headache and vomiting for 8 hours. Now it's settled. What do you want to do? You want to give antiemetic and review after 24 hours, admit and observe, CBC, urine RE, and follow up on the next day, CT brain, lumbar puncture. Now it's a 32 weeks pregnant lady with a history of headache and vomiting for 8 hours. Now the headache and vomiting has been settled. What do you want to do to this patient? That's the question. So what do you think it's a good idea to do? You want to admit and observe, or you want to give antiemetic and review after 24 hours, or you want to do this investigation like CBC, urine RE, and follow up on the next day. Now, doing a CT brain or lumbar puncture at this time is not very important. Okay, because lumbar puncture, the patient doesn't have any fever, so lumbar puncture is not needed in this case. Again, CT brain, if it is settled, then and it's a 32 weeks pregnant lady, we are not thinking about anything sinister or anything serious at the moment. Okay, could be gynecological issues like headache, vomiting, can be due to a lot of problem. Now, antiemetic and review after 24 hours, that's an option. Now, if the vomiting has been settled, there is no need to give antiemetic now at this point. In between B and C, what is the safest option? Safest option, even though this patient headache and vomiting has been settled, this as you guys are also with the B, so yes, it's the safest option is to admit and observe. Remember, like 32 weeks patient having headache and vomiting for 8 hours, the thing is like it's better to be safe rather than sending the patient to the home. The safe option, like maybe headache and vomiting can again come back. We don't know that. Or maybe this could be an indication of something more serious, right? So always it's better if the in pregnant patients, usually it's always better to be more safer rather than becoming less proactive. So it's in my view also it's a good idea for doing admission and observation. Okay. Now, what could be the reason of headache and vomiting in a pregnant patient who is 32 weeks? One of the most important thing is preeclampsia. You should always think about. That's the most important thing we should always rule out. That's why it will be a best idea to do some investigation like urine RME at this time. If there is an option like that, like doing a urine microscopy to see if there is any proteinuria or not, and checking the blood pressure. Because if there is hypertension and headache with a proteinuria, then we can diagnose preeclampsia. So if anything like that is in the option, then choose that. Otherwise, at this moment, it's better to admit and observe just to make sure that this patient is not a serious candidate of having preeclampsia and then complicated by eclampsia. Okay, cool. Any confusion about this question? All right. 8 weeks pregnant patient came with sudden severe left-sided abdominal pain in the low left iliac fossa with vomiting and parvaginal bleeding. Which one of the following feature is of the more concerning for this patient? What's the diagnosis? If a pregnant patient, which is the first trimester pregnant patient, coming to you with sudden severe abdominal pain, vomiting, and PV bleeding, yep, you should always rule out ectopic pregnancy in this patient. Now, ectopic pregnancy can be ruptured, can be unruptured. Our concern if this is a ruptured ectopic pregnancy. How you can find out if it's a ruptured? Yes. So history of PID is not helpful in this case because this is a pregnant patient and having a PV bleeding. PV bleeding has nothing to do with the history of PID. So rule that out. Amenorrhea itself, it's not very important at this time because we know already patient is pregnant. Vaginal bleeding, yes, this is a concerning factor, but just because vaginal bleeding is there, it doesn't mean it's more concerning, rather than if there is a pain which is referring to the tip of the left shoulder, that means that diaphragm is irritated by peritoneal fluid, most likely some blood, which means that if there is ruptured ectopic pregnancy, there will be peritoneal irritation because of the blood in the peritoneum, which we call hemoperitoneum, and that blood can irritate the diaphragm and the phrenic nerve also, and then you can get the referred pain in the tip of the left shoulder. As you can see here, occurrence of acute pain in the tip of the shoulder due to presence of blood or other irritants in the peritoneal cavity when a person is lying down is a classic example of referred pain. Irritation of diaphragm is signaled by the phrenic nerve. This is because the supraclavicular nerve has the same, it's not very important. Now, what is the cause? May result from diaphragmatic or peridiaphragmatic lesion, renal calculi, splenic injury, or ruptured ectopic pregnancy. So this is our answer here. So ruptured ectopic pregnancy can cause this diaphragmatic irritation, and that can lead to the referred pain in the tip of the left shoulder. So that's our most concerning thing in this case. Okay, so this will be our answer. Next, calculation of basal insulin mostly depends on which one of the following. So which one of the following can give you the basal insulin calculation? This is a kind of new question. So you need to have a good idea on how we calculate basal insulin and bolus insulin dose. Let's see. So if you go to this link, you will get all the information that you need to know from for this basal insulin and bolus insulin. There are two types of insulin we give to a patient according to his daily needs. Basal insulin is about 40 to 50% of the daily insulin dose is used during the intervals between meals and at night time, which means that it will give you a constant supply of insulin throughout the day. Okay, and bolus insulin is mainly for like reducing the blood glucose level that is higher than the target level. Also, it will actually neutralize your daily carbohydrate or food intake. Like if you are eating carbohydrate, your glucose will be increased. That increased glucose will be neutralized by this bolus insulin. So these two are, one is bolus, another is basal. We'll go for the basal insulin. calculation. So calculating the basal insulin dose. First, we need to calculate the total daily insulin dose needed by the body. Total daily insulin dose is 40 to 50% of this amount. Now, sorry. So first thing is you need to find out the total daily insulin dose for that particular patient. 40 to 50% of the total insulin dose will be provided by the long-acting or basal insulin. The rest of it will be given by the rapid-acting insulin or bolus insulin. So first thing is to find out the total daily insulin requirement. How you find out total daily insulin requirement is the total body weight in pound divided by 4 or total body weight in kilogram into 0.5. Anything. So body weight is the main thing in here to find out the total insulin requirement. Okay. Now 40% of total insulin requirement will be the basal insulin dose of that patient. Let's assume that a patient's weight is 98 kilo. If it is 98 kilo, what will be the total daily insulin? 98 divided by 0.5, then it becomes 53.9. So keep it as a 54. So 54 unit is the total insulin requirement for this patient. Clear? Now, if you want to find out the basal insulin dose, what you need to do, as you understand that 40 to 50% of this total insulin is your basal insulin requirement. So what is the 40% of 54 unit? 21.6, or 50% of 54 unit is 27. So in between 21 to 27, this is the basal insulin requirement for this particular patient. Okay, so this is how we find out the basal insulin requirement for a patient. You don't need to remember the whole thing, but at least I think it's a good idea to remember that how you find out the total insulin dose requirement for a patient. And it's not very hard. But finding the bolus insulin dose is very hard, so they will not ask you because it's a little complicated. So you don't need to know about that. But finding out the basal insulin dose is easier, so you should know about it. So if you have seen, so calculation of basal insulin depends on what? Weight, GFR, HbA1c, total amount of carbohydrate, RBS. So obviously weight is our answer here, right? And if they ask calculation of bolus insulin depends on which one of the following, bolus insulin calculation is depend on this total amount of carbohydrate you take in a day. I think it's a good idea to learn the formula. We don't know that it will come in the exam or not, but it's easier. So it's a good idea to remember the formula. Next question. 3 years old boy with persistent diarrhea, average body weight, drinks formula milk on feeding bottle. What is the cause? So you have got a patient, you have got a child who is 3 years old having persistent diarrhea, which means chronic diarrhea. Body weight is normal or average, drinks formula milk on feeding bottle. That's the main clue here. So formula milk and having persistent diarrhea. Rule out some of the unlikely causes first. So always in the exam do that, like rule out unimportant or unlikely causes. First of all, you can easily rule out celiac disease because this patient body weight is average. Celiac disease will cause you like severe weight loss. So celiac disease will not be an average body weight. Rule that out. Also, celiac disease patient, there will be some family history of someone on a special diet, and the characteristic of diarrhea for celiac disease will be a like bulky, frothy, explosive, hard to flush, greasy stool. So foul, smelly, hard to flush, greasy stool, that's your celiac disease stool. Then giardiasis. Giardiasis causes watery diarrhea, which is bubbly, explosive, also foul smelly. Giardiasis is mainly associated with history of travel. Okay, very unlikely to be on a 3-year-old who doesn't have any travel history, and already there is a clue of formula milk. Toddler's diarrhea. Toddler's diarrhea is common in infant or common in toddler between 1 to 3 year old. So these 1 to 3 year old children are called toddlers. Diarrhea in toddlers who doesn't have any other underlying cause is mainly toddler's diarrhea. But the main clue for toddler's diarrhea is that they will give you that this child is taking a lot of fruit juices. So lot of fruit juices and having diarrhea without any other underlying cause, that's toddler's diarrhea. Toddler's diarrhea is very common in children who takes a lot of fruit juices, but everything will be fine. Their body weight will be fine. They will be growing well, thriving well, so everything fine. So this one is also unlikely given they haven't given any clue like that. Acute gastro, obviously gastro doesn't cause persistent diarrhea. It usually gets better within few days. Now, only thing remaining is the lactose intolerance. And lactose intolerance is common in on uh, children who takes formula milk or even like cow's milk. So lactose intolerance can happen to anyone who is taking dairy products. Like you can see here. So the commonest offending sugar is the lactose. Usually diarrhea more common after a acute gastroenteritis when milk is reintroduced into the diet. Stool may be watery, frothy, smell like vinegar, and tend to excoriate the buttock. They contain sugar. How to diagnose lactose intolerance? You can do a lactose breath hydrogen test. And treatment is mainly removing any of the offending sugar from the diet, which means that you cannot give this sort of patient, you cannot give formula milk or even sometimes cow's milk. What you can give to this patient, there are milk which do not have lactose. So lactose free milk, which are very commonly available in Australia, we can give it. If lactose free milk is not in the option, then you can give soy milk also. Okay. So in this case, it's most likely lactose intolerance. It causes persistent diarrhea, and usually, if it is not very severe, it will not make your child losing significant body weight. But whenever there is a clue of formula milk on feeding bottle, always think about lactose intolerance can cause a persistent diarrhea in this patient. But still look for other clues in the options or clues in the question. If there is anything that I have described from these options, if anything you found out here, then try to think otherwise. Okay, so always think the toddler's diarrhea, there will be child will be growing well, thriving well, but they give you a clue of that child taking a lot of fruit juices. Gastroenteritis is an acute thing, it should not cause persistent diarrhea. Giardiasis, it's explosive, bubbly, watery diarrhea, usually after a history of travel. Celiac disease, malabsorption. There will be family history of someone on a special diet, which means that gluten-free diet. And also, patient will present to you with a bulky, greasy, hard to flush, foul smelly, bubbly kind of, or foul smelly, frothy stool. And they will have significant loss of body weight. So our patient most likely having lactose intolerance. That's our answer. Clear? Also, you can go to the RCA's guideline for lactose intolerance for more information. Remember, for pediatrics, if you want to find out Australian guideline, always go through the RCH. Next, young men having headache and photophobia on awakening discovers a low-grade fever and resistant to neck flexion, develops nausea and more intense headache, disoriented and inappropriately lethargic. What is your diagnosis? So you have got a patient who is having headache, photophobia, neck stiffness most likely, and also low-grade fever. You have your diagnosis. Everything is given here. What do you think is this patient having? Are you sure that it's meningitis? Always remember, when a patient with features of meningitis having altered mental status, then the diagnosis become encephalitis. So in this patient having fever, headache, photophobia, neck stiffness, that's meningitis. Now, not necessarily there needs to be rash in meningitis. Even with this feature, you can say it's meningitis. But the main thing in here is that this patient is disoriented. That means altered mental status. If there is altered mental status with meningitis feature, the diagnosis becomes encephalitis. See that you know everything, but still, if you don't give very detailed reading of the stem, you can easily miss very easy question, right? So it's very important. See that just one word, disoriented, change the whole scenario. Clear? So it should be encephalitis. Again, migraine doesn't cause fever, neck stiffness. Subarachnoid hemorrhage doesn't cause fever, so unlikely. Meningococcal meningitis can cause everything which this patient having, but not disorientation. When it disoriented or coma, convulsion, okay, confused, that means that patient having encephalitis. Clear? And what is the most common cause of encephalitis? Bacterial, viral, protozoal, what? Viral, good. So viral encephalitis are more common. Now, what is the management if this is a viral encephalitis? What would you give to this patient? Will you give antibiotics or will you give antivirals or will you just do like just paracetamol and take rest? What do you want? Only thing for viral encephalitis is symptomatic management. That means, what is symptomatic management? Give paracetamol for fever or neck pain, and then ask the patient to take a plenty of fluids and take rest. If it is a viral encephalitis, it should go on its own. Only if in the CSF, if you find out this patient having RBC, okay, if this patient having RBC or red blood cell positive in the CSF, that indicates possibility of herpes simplex virus causing encephalitis. In that case, only you should give acyclovir to that patient. Other than that, there is no indication to start a patient with acyclovir. Again, dexamethasone is only for bacterial meningitis because bacterial meningitis can cause a lot of complication. One of the complication is deafness, and dexamethasone can prevent that complication. There is no indication to give dexamethasone in a patient with viral meningitis or encephalitis. Only for bacterial meningitis with antibiotics, you should give dexa. Does this sound good? Any of the herpes, Dr. Josephine, any herpes group, you should give acyclovir. Herpes zoster, herpes simplex, usually we give acyclovir. All right. So that's your meningitis and encephalitis. All right. Next, 12-year-old boy has slightly pigmented pubic hair, slight enlargement of his penis, a pink textured and enlarged scrotum. Which sexual maturation rating this patient is at the moment? The SMR, another name is Tanner staging. So Tanner staging is actually for pubertal staging. So at what stage of puberty a patient is, that's the main question. So you need to remember this staging if you want to find out the answer. How you can find out? Just memorize this chart. It's hard, but still you have to memorize because question can come from here. So what is Tanner stage 1 or SMR 1? Tanner stage 1 means no pubic hair, penis is unchanged, scrotum unchanged. SMR 2 or Tanner stage 2, there will be like a small amount of light pubic hair, just a small amount. Penis will be unchanged or slightly enlarged. Scrotum will be enlarged and some pigmentation, like slight pigmentation, will be there. That's standard stage 2. Stage 3, moderate amount of curly pigmented coarse pubic hair. So more pubic hair will be there. Length of the penis will be increasing. Scrotum will be enlarged. Okay, that's your Tanner stage 3. That means Tanner stage 3 mainly when the penis gets enlarged and pubic hair also increases, then is 3. Stage 4 is the adult stage, which means abundant adult quality pubic hair with penis increasing in both length and width, further enlargement and pigmentation of the scrotum. That's stage 4. Our patient is a 12-year-old boy having slightly pigmented pubic hair and slight enlargement of the penis with a pink textured enlarged scrotum. So slightly pigmented pubic hair. So this one is the small amount of light pubic hair, then slightly enlarged penis and slightly enlarged pigmented scrotum. So this is the Tanner stage 2. All right. So what is your answer? Tanner stage 2. So it's very important to memorize this thing to get to a diagnosis. Okay. 7-pound male infant, normal appearing male with external genitalia, scrotum is empty, no testis palpable in the inguinal canals, appears to be a uterus present as well. What is the most likely cause? So you have got a male infant with both characteristics. That means there is external genitalia, which looks like male, but his scrotum is empty. That means there is no testis. And there is a chance that uterus is there also. So what do you think? Lack of Mullerian inhibiting factor, lack of testosterone, lack of FSAs, lack of LAs. What do you think this patient is having? Now, good. So this is the answer is lack of Mullerian inhibiting factor. Now you need to understand what Mullerian inhibiting factor do for you. If you are a male, Mullerian inhibiting factor is everything that make you male. Okay, so Mullerian inhibiting factor, testosterone, and insulin-like factor 3 which are all produced by the testes, control the male sexual differentiation. Stimulated by the FSH hormone, Sertoli cells will secrete Mullerian inhibiting factor, and that Mullerian inhibiting factor will induce the regression of Mullerian duct. When you don't have Mullerian duct, you don't develop female internal genitalia. Without Mullerian inhibiting factor, Mullerian duct will develop into fallopian tube, uterus, and upper vagina. On the contrary, in response to luteinizing hormone, Leydig cell will produce testosterone, okay, and that testosterone will help you to develop the male secondary sexual characteristics. Also, testosterone will stabilize the Wolffian duct, and from Wolffian duct, you will develop male internal genitalia like epididymis, seminal vesicle, vas deferens. So, all this will come from Wolffian duct. Okay, how you can remember which duct is for male, which duct is for female? Just the opposite. W should be for women, but that's usually giving you the male characteristics. M, Mullerian, M should be male, but opposite, it's giving the female characteristics. So Mullerian and Wolffian, if you just look at the initial letter, just the opposite thing, it will be given by them. Clear? So not necessarily this pathophysiology is important for your exam, but still it's a good thing to know. So as this child having both external genitalia of male and also having uterus, most likely there is lack of Mullerian inhibiting factor that's causing the uterus. And if there is Mullerian inhibiting factor positive, then there will be no testis. Next question. 32-year-old pregnant lady had a stillbirth at 41 weeks. What to do for the next pregnancy? Now, stillbirth in these sort of cases, once you have stillbirth, chances of stillbirth in the next pregnancy also increases. So what you can do to prevent the next pregnancy stillbirth, that is the question. You have option of doing cesarean section at 38 weeks, early delivery, aspirin during pregnancy, increased frequency of fetal surveillance during next pregnancy, avoid further pregnancy as it is very high risk. What do you think? Now, obviously, not necessarily that these will be the option in the exam. It's just a like it could be anything like that. So what you should do, you should read the stillbirth from the Australian guideline, which can help you to find out the exact answer in the exam. So go to this guideline. And this is your Queensland guideline for stillbirth. So these are this is the flow chart of stillbirth care. Antenatal, then what you need to do during labor and birth, and what you want to do for subsequent pregnancy care. This is our question. So any of these options can be there in your exam. So you need to remember that. So consider preconception advice or genetic counseling, offer continuity of care, detailed obstetric history of the parents, lifestyle modification, ultrasound dating and anomaly screening in the initial trimester, consider facility level for anomaly screening. That means do the anomaly screening. Consider serial growth monitoring from 28 weeks if evidence of fetal growth restriction in this pregnancy. So one option is doing a serial fetal growth monitoring from 28 weeks. Another one, you can do antepartum fetal surveillance from 32 weeks, including CTG. Discuss awareness of fetal movement. Consider timing of birth. Okay. Now, if in here, this could be any of the option. Some of the other option you could think about, like if there is any indication of induction of labor, then also we can think about induction of labor before 41 weeks. Normally, we do induction of labor after 41 weeks. But as this patient had a history of stillbirth, you can try the induction of labor before 41 weeks in the next pregnancy, but not a cesarean section. And also, sometimes we give aspirin during pregnancy if only if the patient has a history of antiphospholipid syndrome or if the patient has hypertensive disorder during pregnancy, which is preeclampsia. So during preeclampsia or if there is an antiphospholipid antibody syndrome causing this stillbirth, then aspirin is indicated. Okay. Now from this option, yes, the best option to choose is this one, D. Increased frequency of fetal surveillance during the next pregnancy. Clear? Any question, guys? Yeah, yeah, Dr. Josna. So frequent fetal surveillance is very, very important. If these sort of options are there, always choose that rather than doing an induction of labor without any indication. So what I would suggest to you, go to this guideline and read the full guideline because this is an important topic for you. Next, child came with skin lesion like below. So this is the skin lesion and you started him on antibiotics. When the child will be able to go home? What do you think this lesion is? This yellow honey crusting you can see on the hand, that is impetigo. Okay. And Dr. Josephine, the staphylococcal skin scalded syndrome, it's not like just this single area will be affected. It will affect most of the part of the body, so it's unlikely. Okay. So whenever you will get, most of the time impetigo occurs around the mouth, but sometimes it can happen in the finger also. The good thing is that you have to look at this honey crusting. See this honey crusting? That's your impetigo. And impetigo is one of the skin lesion when you give antibiotic to the child. So when the patient will be able to go to the school, 24 hours later, now 5 days later, no need of school exclusion for this lesion. Obviously, this is impetigo and impetigo needs school exclusion. So D is out. Now, if you look at here, this is from your JM. Impetigo or school sore is a superficial bacterial skin infection caused by either a strep or a staph. If it is a limited area and a small lesion, you can just give topical antibiotic. Mainly, we give Bactroban or Mupirocin. Remember the name, Bactroban and Mupirocin. If it is extensive or the child having fever, very unwell, then you can give oral antibiotics like flucloxacillin or cefalexin. And this is our answer. Child should be excluded from child care settings or school until antibiotic treatment has commenced. So once you start the child with antibiotic, child will be able to go to the school. So what will be your answer here? So now, so child can go to the school now because you have started antibiotics, child can go to school. Cool? And in which case we send the child 24 hours of starting the antibiotic? Scarlet fever. Good, Dr. Ridima. Nice. So scarlet fever, you send the child after 24 hours. And in which condition 5 days later? Chicken pox. Yep. Varicella, right? But do you give antibiotic in varicella? No. So this patient you have given antibiotic. So what should be? Yeah, like normally I don't think is there is anything where we give antibiotic and child goes after 5 days later. So no, it's not like it's usually not no diagnosis like that. Pertussis, yes, pertussis also there is this one is good. So pertussis also we can send the child 5 days after starting the antibiotic, right? So this is the one I was actually asking. Sorry, what type of antibiotic we give to pertussis? What is the name? Erythromycin. Good, great. All right. So that's important. So child can go to the school when you commence antibiotic. Just now, in case of impetigo, 24 hours later, that's a scarlet fever. 5 days later, that's pertussis. Okay, all these three conditions needs antibiotic. Clear? Any questions so far? We're going to take a 10-minute break now, and then we'll again start. Thank you. All right, guys. So let's start again. So you have got a 71-year-old man with coronary artery disease, diabetes, chronic obstructive lung disease, lung cancer, and arthritis, admitted for septic arthritis of the right knee after a recent steroid injection. He undergoes treatment with antibiotics and incision and drainage of the right knee. He reports feeling better with good pain control with hydrocodone. However, on postoperative day 3, he develops acute abdominal distension that is slightly tender on palpation. X-ray given. What is your next appropriate management? Now you have got a patient who is a 71-year-old gentleman having acute abdominal distension, which is slightly tender on palpation. Looking at the X-ray, this is the X-ray how it looks like. You can see what you understand from here. Is it a large bowel or a small bowel? By the look of it, see that this is called haustral fold. You can see, right? These are the haustral fold, and haustral folds are characteristic of large bowel. And large bowel also always will be in the periphery. So you can see these are all distended colon. Always when you look at the large bowel, look at the rectum, this area. In the rectal area, you can see there is some gas shadows, right? If you see gas shadows coming up to the rectum, what is your diagnosis? The diagnosis is pseudo obstruction, which means that there is no mechanical obstruction, it's just a functional obstruction, which is very common in patients who are elderly with on multiple medication, especially on narcotic analgesia. Like in this case, this patient is on hydrocodone, which is an opioid analgesia, and this sort of opioids can cause this pseudo obstruction. Also, the patient with Parkinsonism who takes levodopa can have pseudo obstruction. Okay, now let me show you the link. So go to the med bullets. So this is your pseudo obstruction. Now, pseudo obstruction indicated by large intestinal dilation in the absence of any mechanical obstruction. Risk factor mainly elderly, narcotics, anticholinergic drugs, recent surgery, sepsis, malignancy. Patient will present to you with a similar feature of large bowel obstruction like abdominal distension, constipation, abdominal pain, and later on vomiting. To diagnose this condition, first of all, you have to do a X-ray abdomen. X-ray abdomen will not be able to differentiate between mechanical obstruction and pseudo obstruction. To differentiate between a mechanical obstruction and a functional or pseudo obstruction, you have to do either gastrographin enema, or if gastrographin enema is not in the option, then you can do CT abdomen as well. Any of these two are okay. But according to your JM, gastrographin enema is the confirmatory diagnosis. So if gastrographin is there, we would do the gastrographin enema. Otherwise, CT abdomen. After you have done that investigation, then it will confirm if there is mechanical obstruction or pseudo obstruction. Now, if it is a pseudo obstruction, the first line treatment is stop any offending medication that can aggravate this pseudo obstruction. That's the first thing. And we will start with the conservative management, which means nothing by mouth, intravenous fluid, and nasogastric tube decompression. This is the any bowel obstruction, this is the conservative treatment we start with. After that, second line will be giving neostigmine. If within 24 hours to 48 hours of conservative treatment, there is no resolution of symptoms, then you give neostigmine. Okay. If neostigmine doesn't relieve the symptom, then the third line is colonoscopic decompression And the lastly, if nothing helps, then you need to go for surgery, which is cecostomy. Okay, so you have to remember this stepwise management because it's very important. So for pseudo obstruction, first line is conservative management, second line neostigmine, third line colonoscopic decompression, fourth line is cecostomy. Clear? Now in this case, what you want to do? You want to keep the patient on nothing by mouth and IV fluid, nasogastric decompression, stop hydrocodone, neostigmine, colonoscopic decompression. What do you think you should do now? First thing first, stop offending medication. So first of all, you have to stop the hydrocodone in here. That's your answer. Then later on, you will put the patient on NBM and IV fluid, then nasogastric decompression. That's all right. But they are asking to you, what is the next appropriate management? Next appropriate means, what's the first thing you are going to do for this patient? Stop hydrocodone. Next, 33-year-old female comes to you asking for contraception as she has started new sexual life with her boyfriend. She has a past history of deep vein thrombosis. What contraceptive advice you will give to her? Whenever contraceptive advice comes, always choose the best, which is the best for her. She's a 33-year-old. For a 33-year-old female, the best is always Mirena. Okay, because Mirena is a progesterone only kind of hormonal contraceptive. That means Mirena will contain only progesterone, and any progesterone containing pill or device will not have any effect on clotting problems. So any patient having DVT, use progesterone only contraception because it is not associated with risk of increased venous thromboembolism. Now, depending on the factor, depending on the age, we need to choose the most appropriate one. You can obviously choose condom, POP, DMPA, Mirena, all you can choose in this patient, but you cannot choose this one, COCP, because COCP is contraindicated for a patient with DVT. But others you can choose. But for all these options, the best option is Mirena, always. Okay. Aboriginal kid, 9 years old, came to see you because since 2 days he is having ankle edema. First of all, Aboriginal, that's a clue, having ankle edema. What is the next best step for this patient? What is the diagnosis for an Aboriginal 9 years old kid having an ankle edema? What do you think? Remember, nephrotic syndrome is not that common in Aboriginal rather than glomerulonephritis. Yes, post-streptococcal glomerulonephritis is very common in Aboriginal patients. In other Australian kid, that if ankle edema was the complaint, we would think about nephrotic syndrome at that time. And you should not think about rheumatic fever when a patient only comes to you with ankle edema. Rheumatic fever doesn't cause ankle edema. Okay. Now, PSGN or post-streptococcal glomerulonephritis, it usually occurs after some throat infection or skin infection like impetigo. And this skin infection, throat infection are common in Aboriginal kids. Okay, so what is the next step to diagnose PSGN in this patient? Now, look at the question. Ankle edema is the only complaint. There is no other things written here. Sometimes they would give you that patient had a preceding throat infection 1 week ago, or they would give you some hematuria, proteinuria, something they would give it to you. Nothing is given here. What is the next thing you would do if this patient came to you? Anti-streptolysin O, throat swab, C3, C4, urine MCS, furosemide. Now look at the guideline from Australia. Be very careful when you choose options. When remember one thing, when the question seems very easy, there are some problem in that question. Always remember that, and be very, very cautious when you answer those easy questions. To diagnose acute post-streptococcal glomerulonephritis, you have to have at least two of the following. One, facial edema or peripheral edema, hypertension, or more than equal, like you have to have some hematuria on dipstick. So either any of these three, at least two should be there: hypertension, hematuria, or peripheral edema and facial edema. Our patient having only one, that means only ankle edema. Now I need another one at least. Okay, that's one thing. Another one is laboratory evidence will be also required to confirm your diagnosis. First thing is hematuria on microscopy. So it's very important to do a urine dipstick or urine microscopy for this sort of patient to find out hematuria. Maybe it could be a microscopic hematuria, because then the patient will not be even know that they are having hematuria. So microscopic hematuria patient, the color of the urine will be totally normal. When you do the microscopy, then you will find out some red blood cell. After that, you have to find the evidence of recent streptococcal infection, which you can find out by doing a ASO titer, anti-DNS-B, or throat swab, and reduced C3 complement level. So these are the stepwise investigation you will do in a APS-GN case. A confirmed case requires both clinical evidence and laboratory evidence. Okay, so we need all these things to diagnose this case. So first of all, what you would do in this patient before you do this ASO titer, throat swab, what is the most important thing you should find out? You should find out urine MCS first. That means hematuria first. First do the hematuria, and then after that you will do the anti-streptolysin O. The previous one answer is Mirena. Okay, and in this case it will be urine MCS will be our most likely next best step. After urine MCS will show you some RBC in the urine. Then what you want to do, you between throat swab and anti-streptolysin, better to do an anti-streptolysin if it is there. If that is not in the option, then throat swab. And doing and giving furosemide is not needed at this time. Okay. C3, C4, C3, C4 complement will be low in PSG, and we can do it as a additional investigation, but it will not confirm anything. Yep. If there is a history of sore throat, then doing a throat swab is more better, right? All right. Any question, any confusion so far? So if there is a sore throat feature or sore throat history, then better to do a swab from the throat. If that is not in the history, then anti-streptolysin O we will do. Next, child of 6-year-old is coming with his mom cause he's having a perianal pain. You can see multiple scars and bruises. When you are going to do the physical examination, he refused. What would you suspect? Child abuse, ADHD, anal fissure, constipation, oppositional defiant disorder. So obviously, like this one is the main clue here. You can see multiple scars and bruises, okay, and having perianal pain. So obviously, we should think about child abuse as our first diagnosis, not the others. Next, 26 years old girl came with his husband. They want to have babies. They have been trying since 6 months, but unsuccessful outcomes. Her BMI is 29. On examination, there is hirsutism. What is the next best step for this patient? So, what is your diagnosis for this patient? 26-year-old, obese, having hirsutism. So, yes, very good. So, it's a polycystic ovarian syndrome. So, polycystic ovarian syndrome characterized by this sort of problem. That means they will have subfertility, they will have obesity, acne, hirsutism. Okay. Now, they have been trying just for 6 months. What is the first line treatment for PCOS? Is just for 6 months. You cannot even say that it's subfertility unless you are trying for 1 year. Okay. If this patient was trying 1 year, then still no baby, then we can keep it in the subfertility range. At this point of time, it's better to try the lifestyle modification, which is weight loss. Even only weight loss can give the chances or can increase the chances of having the baby. Okay, so just lifestyle modification will be our first line option. If that doesn't help, then you can try the other methods. You can try metformin, you can try clomiphene citrate. But the best option for PCOS patient who is having difficulty with conception is the clomiphene citrate. If clomiphene citrate is not in the option, then metformin. Now, you don't need to start with metformin for losing weight, Dr. Joshna. Okay? Yeah, even if HbA1c is high, okay, like your glucose intolerance is done by the increased obesity. So, even if HbA1c high, whatever it is, we will start with the lifestyle modification first. Lifestyle modification doesn't help, then depending on the complication, we will choose our next treatment. Like as you said, if HbA1c high, that means this patient is having glucose intolerance. At that time, you have to start with metformin. If the patient having irregular period, then start with OCP. Having acne, give OCP. If the patient having hirsutism, that's the problem, then you can start with OCP or try laser treatment. If problem with the subfertility, then obviously best option is clomiphene after weight loss. Sometimes clomiphene might not be in the option. Metformin can be the next better option to choose in that case. No, remember this is very well written in your JM. Your first line treatment is always lifestyle modification, which is you're making an ideal body weight. That's always. Okay, for BMI 29, you don't need to start metformin for this patient. Okay, Never ever start with medication when you have lifestyle in your hand. That's the best management for anyone. Yeah, Dr. Sefi, right. Even a minimal amount of weight loss can restore the ovulatory cycle. That's written in the handbook also. And yes, good question. So what about investigation in case of PCOS? PCOS patient, there are options that you can do. Best thing to do is the checking the serum testosterone. That will be high. That is the confirmatory or best investigation. You can do abdominal or pelvic ultrasound in which you will get more than 10 to 12 cysts in each of the ovary. Then you can say it's a PCOS. But that's not confirmatory. It's the adjunctive modality of investigation. And sometimes in the question, they will give you a FSH LH ratio. That's very highly effective to at least think about PCOS. In a normal person, FSH LH ratio should be 3:1. When this ratio interchanged, that means FSH LH ratio becomes 1:3, then you should always think about PCOS. Okay, so this ratio can at least help you to think about PCOS, but it's not a confirmatory investigation. Confirmatory is serum testosterone. Because of increased serum testosterone, you will have hirsutism, acne, all these things. Clear? So for PCOS, your first of all, initially you can check the hormonal level, FSH, LH, but best is serum testosterone. Management, first of all, always weight loss or lifestyle modification. Usually we try it for 3 to 6 months. That doesn't help, then depending on what is the most important cause of presentation of this patient to you, depending on that we will treat it. Like problem is the subfertility, we will give clomiphene. Problem is weight loss, okay, metformin. Or problem is with irregular menstruation, OCP. Problem mainly in increased acne, OCP. Problem with hirsutism, we can try OCP, but better is to try with some laser treatment and more other sophisticated treatment. So depending on what is the presenting complaint of the patient, you need to treat it. Now, if, as someone asked, if there is both high HbA1c and subfertility, then you have to think, or in the question, they will give you that patient presented to you with a history of subfertility or patient is unable to get babies. So that's the main complaint. Okay. Now, high HbA1c, even if after trying weight loss, if that doesn't help, then we have to start with metformin. In such situation, if both HbA1c and subfertility is there, you can start with the metformin, see if that helps. Okay, if that doesn't help, then you have to go for clomiphene for fertility. But it depends on the age of the patient. Like if a 34-year-old patient coming to you with a PCOS problem, having high HbA1c and subfertility, you don't have time to do like give weight loss, like try weight loss, then try metformin, then try clomiphene. That you don't have that much time, because when the age of the patient is getting increased, chances of pregnancy is reducing. So at that time, go for the clomiphene. Okay, if it is a like elderly patient coming to you with like subfertility problem. Clear? Serum is Dr. Firoz, serum estrogen will not do anything for you in this PCOS. You have to do the FSH LS. That's the initially you can try with that. Estrogen, doing an estrogen will not do anything. Again, Dr. Mimu Ghosh, in this case, like if it's the PCOS, it's a reversible cause of fertility, right? It's not irreversible that you need to start with the immediate management. For a 26-year-old girl, even if they have been trying for 1 year, you should start with the lifestyle modification first, 3 to 6 months. That doesn't help, then you go for clomiphene. Again, Dr. Sylvia, young girl with PCOS, with obesity, hirsutism. Initially, you should start with lifestyle modification. If lifestyle modification doesn't help, then you have to find out what's the main complaint of the patient. Is the obesity is the main problem or hirsutism is the main problem? Because OCP cannot help you with the obesity, right? OCP can help you with hirsutism. So in that case, you have to try like others thing. Like for obesity, try metformin. For hirsutism, try laser treatment. Clear? So it depends on what's the main complaint of the patient. In that way, we would treat. Next, patient with knee swelling and pain, perform an arthrocentesis. Fluid analysis reveals rhomboid-shaped, positively birefringent crystal with WBC 30,000. What is the diagnosis? WBC 30,000, patient having knee swelling and pain. The good thing is that we have found a crystal. There are mainly two crystals we need to remember. One is for gout, another is for pseudo gout. In gout, you will get a negatively birefringent needle-like crystal. In case of pseudo gout, where you have calcium pyrophosphate deposition in the joint, you will get positively birefringent rhomboid-shaped crystal. Now, someone may be confused with this WBC increase. Any inflammatory change can increase your WBC. If it is more than 50,000, then we could think about some septic arthritis. But for less than 50,000, we don't need to think about it. This WBC is most likely due to inflammation going on due to gout. So this patient is having pseudo gout because positively birefringent crystal. Okay. Next, 4-year-old child at the emergency room with erythematous rash and temperature of 40 degrees Celsius. Desquamation of skin occurs with gentle traction. What is the diagnosis? So there is one condition called epidermolysis bullosa, staphylococcal scarlet skin syndrome, herpes simplex, roseola infantum, Kawasaki disease. What do you think this patient has got? First of all, let's rule out some of the options. Herpes simplex, it doesn't come with desquamation or high fever like this, so rule that out. Epidermolysis bullosa, it's a blistering kind of condition. So a patient will usually develop a lot of blister rather than fever, rash, or desquamation. And see that they will develop like bullous disease. Roseola infantum, it causes high fever like around 40 degrees Celsius, but the characteristic is that after 3 to 4 days, fever subsides, and after that, the rash appears, but it doesn't cause desquamation. So, Roseola infantum is also out. Kawasaki disease is a good option in here. Like Kawasaki disease will cause high fever, and it's common in less than 5-year-old child, but Kawasaki disease has other symptoms like they will have this polymorphous rash. Erythematous rash can be there, but polymorphous rash will be there. There will be conjunctival redness. There will be cervical lymphadenopathy. There will be a strawberry tongue, dry cracked lips. There will be erythema and swelling of the hands and feet. And later on, at the convalescent phase, that means when the child will gets better, they will have desquamation. But this patient is at the moment having fever, rash, so it's not the convalescent phase. At this time, having desquamation, unlikely to be a Kawasaki disease. But it was a good option to choose. Now, other one is your staphylococcal scalded skin syndrome. Now, what it is, let's have a look. So, staphylococcal scalded skin syndrome is a serious skin infection caused by the bacterium Staph aureus. These bacteria produce a kind of toxin that causes the outer layer of the skin to blister and peel. Okay, so outer layer of the skin will desquamate like that. So this is a characteristic finding of staphylococcal scalded skin syndrome. Symptoms: child can have fever, irritability, chills, weakness, conjunctivitis. This thing can be there, and you will get a red, tender skin, easily broken blister, and peeling skin. So main thing is that when the child will have fever, then there will be formation of blister. That blister will burst easily, and then there will be a red erythematous lesion. And also on the top of that, there will be desquamation of the outer layer of the skin. Now, erythematous rash is the, like when the blister opens, then you can get this erythematous rash or erythema, you can say. How to manage treatment? Because it's a bacterial infection, you have to give flucloxacillin mainly for this infection. Okay, so most likely I'm still with the staphylococcal scalded skin syndrome, but it still depends on the exam question, how they give it to you. Could be a Kawasaki also if they change the question a little bit. Clear? Any question of this one? Now, someone of you asked question about the PCOS. Let me just have a look. Mm, 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 mm. Dr. Firoz Khan, see that FSH LH ratio is not a confirmatory diagnosis for PCOS. For PCOS, your confirmatory test is serum testosterone. Okay. Now it depends on what they asked it to you. If they are giving you PCOS scenario and then asking for what is the next investigation you are going to do. Next investigation, we will start with the hormone test. Now, if that hormone contains FSAs, LAs, testosterone, then it is very good. But if there is two options, like if it says LAs and another option is testosterone, we would start with the FSAs, LAs first, and later on we will confirm with the testosterone. The mainly people get confused with the ultrasound, but remember ultrasound is not a confirmatory diagnosis for PCOS. Is the serum testosterone. Okay. Next, 27-year-old woman who is a 36 weeks pregnant comes to you and saying that her husband is abusing her. What you are going to do now? Inform the police, take pictures and attach them to the report, tell her to go home, come back later, admit her to the hospital, discuss with the husband. Now remember one thing, domestic abuse, you should never ever inform the police by yourself. Okay, that's the first thing, because I know that most of you will choose this one who doesn't have the idea about how we deal with domestic abuse. Domestic abuse only if the patient wants to inform to the police, then you can do it, or you can give the number of the police to her. She can contact with the police, but you by yourself without any consent from the patient, you don't inform the police for domestic violence. Clear? Again, for this patient who is a 36 weeks pregnant lady, you need to give her some shelter. Either you can send her to a shelter home, or you can admit her to the hospital where you can involve the social worker, and social worker can do the rest of the thing. Any of these two options is a good option to choose. In here, I cannot see any shelter. I can see only admit her to the hospital. That's the best option for a safety of the patient. Okay. So anyone having this sort of domestic violence, the main thing is to offer her shelter home. Okay. You can say about informing the police. If she gives consent to you, then only you can inform. Otherwise, no indication. Okay. Any of this violence, like any family violence like elderly abuse, domestic violence, any of these cases, we need the patient consent to inform the police. We just don't do it by ourselves. Now, taking photos are also a part of the management, but not the best management. Like obviously, if you find out some bruises, some cuts mark, some injury mark, you will take some picture with the consent of the patient. So that consent should be here, like take picture with the consent of the patient. Without consent, again, you cannot take picture. And you can take picture after admitting her to the hospital, making her safe, and then do that. You can do that, okay? So the best thing for any abuse is make her safe first, rather than taking picture and blah, blah, blah. Just for child abuse, you have to go for child protective authority. Okay, so just in that case, in child abuse case, you have to inform the child protection authority even without any consent of any parents or anyone. You don't need to ask, discuss with the parents or anything. Everything will be done by the CPA. So child protective authority, first thing, if you think, like even if you just think that it could be a child abuse, you should always inform the CPA. Even if you are wrong, that's not a problem. Okay. Yeah, so next thing is admit her to the hospital, involve the social worker will do the rest of the thing, like providing a shelter for this patient, providing some financial support. So all the support will be arranged by the social worker later on. 16 weeks baby is lethargic, dehydrated, fever 39, and has rash in his trunk. What would you do? Like in neonate, I can say like 16-week, which means like 4-month old baby having fever, rash, and dehydration. That's what's your diagnosis? Fever, rash in a baby. Always our first thing to remember is meningococcal meningitis. That's most likely diagnosis in here. On the top of that, child is lethargic, dehydrated. So obviously this patient is a meningococcal meningitis. You have to take the blood culture and start the antibiotic as soon as possible. Nothing else. So blood culture, if you can take it, otherwise if the child is very severe, even without blood culture, we will start with antibiotic. What antibiotic you give for meningococcal meningitis to a child? Good. Ceftriaxone. So you have to give ceftriaxone, not benzyl penicillin. Okay. So many candidates choose benzyl penicillin because in one of the chapter of JM there is benzyl penicillin written, but it's in your handbook. It's well written that ceftriaxone should be given, or cefotaxime. Okay. All right. 67-year-old women presents with red tender finger like this, hard to move. What is your diagnosis? Septic arthritis, gout, pseudogout, rheumatoid arthritis, osteoarthritis. Look at the picture. You see that this whitish thing you can see, this whitish thing is nothing but the tophi. Okay. This is the only nodule which will look like this, some calcium deposition. Okay. So anytime you see this whitish kind of nodule, it's gout. You don't need to think about anything else. Okay. Haverdon nodes can be there in osteoarthritis, but it will not like, it will never ever looks like this. Septic arthritis will be totally red, inflamed. Okay. So this is gout. Very important to have a look into the pictures. You can easily look into the rheumatoid arthritis nodules, osteoarthritis nodules in the Google. Very important to have an understanding on that. 37-year-old patient coming because of shortness of breath, fever. Physical examination shows decreased breath sound of the right side. Patient is able to talk. X-ray given below. What should you do next? What is your diagnosis? Fever, shortness of breath with this kind of chest X-ray. Yeah, it's not empyema. Always think about it's most likely, see this concavity upwards, okay? And you cannot see costophrenic angle. You cannot see costocardiac angle. This is pleural effusion. And most likely it's a parapneumonic effusion. That means pneumonia with effusion, which we call parapneumonic effusion, which is a complicated form of pneumonia. Complicated pneumonia mainly includes parapneumonic effusion and empyema. Empyema will have very high fever with chills and rigors, and empyema will not give you this kind of X-ray. Okay, I'll show you the empyema X-ray. Okay, now in this case, any complicated pneumonia is regarded as a severe pneumonia. That means you have to treat it like a severe pneumonia. What is the severe pneumonia management? So you want to do a bronchoscopy, pleural fluid drainage, discharge home, never, flucloxacillin. Now, based on these options, better is to go for fluclox, but still we usually would start this patient with ceftriaxone. Ceftriaxone, azithromycin, and flucloxacillin. These are the main treatment for severe pneumonia. Now let me discuss this pneumonia a little bit for you guys. Very important for your exam to understand the pneumonia treatment. Pneumonia can be divided into mild, moderate, and severe in case of adult patient. Mild pneumonia means that patient having pneumonia-like feature like fever, shortness of breath, but it's manageable. Like no other features of severe pneumonia. You find out the severity of pneumonia by curve 65. Curve 65, C for confusion, urea more than 7, R means respiratory rate more than 30, B means blood pressure less than 90/60, and A is more than 65. Curve 65 more than equal 1 becomes severe. Okay. So for severe pneumonia, we usually would admit the patient, and if the curve 65 becomes more than equal to ICU admission. Okay. Now for severe pneumonia, C according to the JM, you can give azithromycin plus ceftriaxone, and you can add fluclox also. But main treatment is ceftriaxone with azithromycin. Azithromycin will cover the atypical pneumonia. Ceftriaxone will cover the mainly bacterial. And if it is a staph aureus, then fluclox will cover that. Okay, it's a broad spectrum antibiotic. Now, severity of pneumonia, also you should look for this thing, that altered mental status, rapidly deteriorating, respiratory rate more than 30, pulse rate more than 100, patient is having hypotension, curve 65 more than equal to, hypoxia, that means saturation going down to less than 92. Okay, in these cases, we have to admit the patient and start with IV antibiotics. In mild pneumonia, who can tolerate oral antibiotic and not very much severe, those patients you can treat as an outpatient with oral antibiotic, mainly augmentin, which is your amoxicillin and clavulanic acid, and you can add roxithromycin or doxycycline to cover the atypical pneumonia. Now, some of the patient with mild symptoms, but like in between mild and severe, and they cannot tolerate oral antibiotic, like having vomiting, or their age is over 65, but not very much severe, or age over 65, but doesn't have high respiratory rate, doesn't have hypoxia, okay? But those patients cannot tolerate oral therapy. In that case, you can give that patient IV benzyl penicillin. Okay, that's the only time you give IV benzyl penicillin, when a patient is unable to tolerate oral therapy. Or if it's an elderly patient having multiple comorbidities and is a little sick looking or ill looking. Clear? But if you want to give azithromycin, ceftriaxone, or fluclox, they need to be in this criteria. Also, if a patient has complicated pneumonia like parapneumonic effusion or empyema, IV antibiotic should be started. Okay, if you go into this RCH guideline of pleural effusion and empyema, you will find it out. Always think about complicated pneumonia if a patient is on antibiotic, oral antibiotic, but clinically not improving within 48 hours. So persistent fever after 48 hours of pneumonia treatment, you should think about complication. So do a chest x-ray to find out effusion or empyema. If you found fluid, you have to start with IV antibiotics to this patient. But before you start IV antibiotic, always take a blood culture because it will help you to find out the organism. After taking the blood culture, then you start with IV antibiotics. And IV antibiotics, especially, we will start with ceftriaxone or fluclox and also azithro. But best option is ceftriaxone. But in here, ceftriaxone is not in the option. We will choose fluclox. Clear? Any problem with pneumonia? You aspirate fluid, usually like you are treating the patient with antibiotic, but it's still symptoms is not resolving and having severe shortness of breath because of large effusion. When there is large effusion and it's complicating with the breathing of the patient, then you have to aspirate the fluid. Or mainly we do the pleural fluid drainage at that time. Next question. Patient was doing gardening yesterday and today he came to the emergency department because his hand is red, swollen and painful. What would you do next? So main clue is patient doing gardening yesterday. Now, one of his hand is red, swollen, painful. So you want to start with admission and antibiotic, X-ray, exploration debridement, refer to ortho, tetanus injection. What do you want to do? Now, first thing to do, if there is any option of analgesia, you should give that. Now, next thing, like during gardening, what if something inserted into the finger? What if there was something which inserted into the finger and that's causing the infection? Like during gardening, anything can get into your finger, right? So to find that out, even before you explore or debride, not every patient will need exploration and debridement. It depends on the severity of the condition. Sometimes you can just give antibiotics and see how that goes. Okay, the best thing at this time is to do an X-ray, find out if there is anything into the hand. You can do either X-ray or ultrasound. Any of these option would be a good option to choose. And again, tetanus is not needed at this time unless you find out anything in the X-ray. If in the during the X-ray, if you find out like there is something inside the finger, then you can give a tetanus because at that time you know that there is a possibility of tetanus infection or there is a possibility of like more infection if you don't give the tetanus immunization at this patient. And also they did not say that if the hand is having any cut or if the hand is like having any wound infection. Okay, if it was a wound infection, then the debridement exploration would be a choice. But even if you debride or explore, we do a X-ray first to find out if there is anything. Because first of all, you need to make sure there is nothing inside. Because if you do an X-ray, then you will be aware that during exploration, I have to remove that also. Now, what if you did the debridement and exploration and It's not like just washing the hand. When you do debridement exploration, you have to insert local anesthetics, everything you have to do. Sometimes this patient needs to be in the operation theater also for just debridement. And after debridement, then you send the patient to the X-ray, and X-ray shows there is something inside the hand. Then what you will do? You will do again debridement. So to avoid those sort of problem, we do an X-ray. X-ray is very easily available in any hospital. You can do the X-ray, then do other things. Okay. So in any time, if there is a possibility that something can be into the bone, something can be into the muscle that could cause this infection, we always do an X-ray first. Okay. That's always in the emergency department that should be done. Now, again, if it is a lacerated wound due to a cut injury, not gardening, okay, like patient was doing some work with some machine, and due to from the machine, patient got some laceration. At that time, you don't need to do an X-ray because there is unlikely something will be there in the region, right? So then you can do the debridement and exploration. That's okay. So it depends on the mechanism of injury. If there is any chance that the patient can have a possibility of bone injury, we do an X-ray first. Okay, because exploration debridement, most of the time it will be done by an orthopedic or surgeon. So they usually take this patient to the OT and then do the debridement exploration under local or even sometimes general anesthesia. It sounds like this, but yeah, in Australia, they try to make sure there is no pain when we do this sort of debridement or exploration. So because it was a gardening and they did not say any laceration, it's just the hand is red and swollen. It could be something inside, we don't know. Better to do an X-ray first to rule out if there is anything into the muscle or bone. Clear? Yes, Dr. Shehar, yeah. So if there is cut, laceration, there is a possibility of tetanus. So in that case, you have to give the tetanus injection also. But that's not your first line. That's an adjunctive thing we will do. Now we don't know, Dr. Mimo, that we don't know that it's a organic or non-organic. Okay, like first thing is like it could be something like, what can I say, like some flower, from some flower some stick can go into the arm, anything can go into the hand, even patient might not notice it. All right, we can do an X-ray or ultrasound, any of those two, and try to find out if there is anything in there. Now obviously this is a cellulitis, okay, because red swollen painful means cellulitis, but that cellulitis should have some underlying cause, and they have given us clue that patient was doing gardening yesterday and then this started. The safer approach is to do either X-ray or ultrasound to find out if there is anything in the hand before doing the exploration debridement. All right, any question? Now the last option today, patient with pericarditis. He is also on gentamicin, levels normal. Since 2 days, he's been having dizziness and ear discomfort. What is the diagnosis? nephrotoxicity, ototoxicity, ASOM, CSM, serous otitis media. Very common complication of gentamicin is nephrotoxicity and ototoxicity. Now, this patient is on gentamicin and having some ear discomfort and dizziness. Most likely, it's ototoxicity. In case of gentamicin, the ototoxicity that happens is a kind of sensory neural hearing loss happens, and also it's most of the time it's a symmetrical. That means both ears will be affected most of the time in this case. Okay, so that's all about our today's session. I hope that this class was helpful for you. Any question from today's session? Now, as you know that this will be our last free session. So after that, we will take class in our course and only the course student will be able to join. So if there is still any one of you who wants to join our next 5 months course, but you still haven't been contacted or you haven't sent us an email or anything, make sure you do that. Okay. So thank you all. It was really nice to have many of you in the class and it was really interactive. We will upload the schedule, Dr. Raymond, in your sessions, in your course group. Okay. Now, I know that someone of you might have exam in November, and November is a time when many candidates will appear, right? So the first thing is that I know that most of you who are appearing November exam, you are well prepared, okay? Because throughout this year you have prepared. So you know the question pattern, you know how to answer. So just be confident. Don't feel like you don't know. And remember one thing, you will always be scared before the exam, and it's very common. And you will feel like you don't know anything and you forgot everything. But when you appear the exam, you will find out that yes, you remember things. That's very common. Now, what you can do, you should try to revise what you have read. Don't try anything new because it will just make you confused. Okay, try to appear some mock exams if you still haven't, because it will give you some idea about how to do the time management. At least try to take 150 question mock test once before you go for the exam. That will help you to understand and orient with the exam. Then what you should do before the exam, make sure you revise some of the questions which are important. Make sure you revise the screening questions. Make sure you do some of the revision of theory which you always used to forget. Okay, just a eye looking, like don't go deep, just in very short time, just a eye view that yeah, this is just in a very short time, just give a read. And during examination, when you appear the exam and in the exam hall, don't waste your time with just one single question, because the question you are wasting time might be there is a pilot question. Okay, so some of the question will be very hard. That's normal. Everyone will have hard questions. Just click on any of the option, then move on. Make sure you flag that option so that when you finish the whole 150 question, then you can able to come back to this question and then give some more time to find out the answer. First of all, finish your 150 question as soon as possible. And make sure you finish it, because if you don't finish it and don't click on the submit button and confirm it, your exam will come as a fail. Sometimes many students do, like there are some moderators in that room, right? When you appear the exam, when you finish your exam, you just ask the moderator that I finished my exam, and then moderator says yes, you can left if you want. So and you left without submitting your answer, and somehow the moderator also missed that, and you fail that case. We have students like that before. So make sure that you don't do the same thing. Okay, it's very important. Like you may pass that exam if you would not do that. Okay, and remember the last 20 questions are scored questions, and those are vital questions. So make sure you have some spare time for the last 20 questions. And in the exam, they will provide you uh, one paper. It's not kind of paper where you can write. If you are having some confusion, or if you want to uh, calculate something, they will provide you a kind of paper to write something. So pen and paper will be there. You can write if you want to like come back to this question. Something you can do in your paper also. But always flag the questions which you are confused about. Okay. So that's actually all that you should do at the moment, and pray to your God that pass this exam with one go. Okay. Remember, MCQ is easy to pass. That's that's the thing. Don't fail. Okay. You are more than prepared to appear the exam, because most of you who are appearing November, I know that you have been trying a lot. You have been trying hard throughout this year, and this year was not what you guys expected. But obviously, this year, if you pass this exam in one attempt, then everything that you have done will be successful. There is no passing mark. Okay, the AMC, the passing is actually done by the AMC scale, and that scale, how that hell that works, no one knows. But you have to, the total mark is 500. You have to get more than equal to 50 to pass. Also in that, there are some things like mastery questions you have to pass. You have to correct 60% of mastery questions also. So AMC scale is a kind of a scale which will show you like how it's not depends on how much you have scored right. It depends on how much difficult question, how much easy question you have done right. So it's a kind of a skill, only they know how this thing runs. But AMC scale will show you pass or fail. So mainly if you want to know the mark, that means 250 mark is actually they said pass. But that 250 mark usually comes after the AMC scale. AMC scale will define your mark. Okay. It's not like someone can score 120 question correct out of 150, or someone can just make it correct like 90 question, but that 90 question person can pass the exam, and 120 question person can fail the exam. It depends on the AMC skill, how how much difficult question you have answered, and if you haven't answered correctly any of the mastery questions. So many things will depend. And I meant that at the end of your 150 question, there will be an option that you want to finish the exam. So there will be a button like finish. So you have to click the finish, and then they will confirm you that are you sure that you want to finish and submit your answer. Then you click yes, and then your exam will be submitted. All right then. So this was all about today's session. Thank you all for joining. Have a good sleep, and I hope that all of you who appeared the exam pass it one in one go. Okay. Thank you. Have a good night. Bye.